Welcome back from the break. We've just finished going over our rapid review of aortic regurgitation and stenosis in the ESC guidelines, and we will now move on to our rapid review of mitral regurgitation and stenosis in the ESC guidelines. If you're ever looking to dive into this topic beyond the brief time allotted to us today, please listen to episodes 4.08 to 4.11 in my board review podcast, Who Said, which you can find on Spotify and Apple Podcasts. Today's slides are also posted on my YouTube channel. Here are the knowledge competencies required by the ESC. Once again, we will not have time to touch on every single one of these, but we will make our way through the most high yield items. The first half of the talk will be about mitral regurgitation, and the second half will be about mitral stenosis. Starting off with fundamentals. What does the murmur of mitral regurgitation sound like? The timing is holosystolic, extending from S1 to S2. It is plateau-shaped, is heard at the apex, and radiates to the back or axilla if it's a posterior MR jet, and radiates to the left lower sternal border if it is an anterior MR jet. The intensity is proportional to the pressure gradient between LV and LA during systole, and it increases with hand grip, which increases afterload. Let's take a listen to what the murmur of mitral regurgitation sounds like. Now, what about the murmur of mitral prolapse? You're going to have a mid-systolic click plus a late systolic murmur. The late systolic murmur may be absent in some patients. It is heard at the apex. The click is also heard at the precordium. And it indicates one or more mitral leaflets are displaced at least 2 millimeters from the mitral annulus into the left atrium and echo. Could be from myxomatous degeneration, elongation, and subsequently chordal rupture. The way it happens is as blood flows retrogradely from the left ventricle to the left atrium, mitral valves maintain themselves at first, but then chordae tendineae suddenly prolapse and tense up, which you hear as a mid-systolic click. Maneuvers that reduce left ventricular volume, such as Valsalva, or standing, which decreases preload, cause the mitral valve to prolapse into the left atrium sooner, pulling the click forward from mid to early systole and increasing the duration of the systolic murmur. Conversely, maneuvers that increase impedance to LV emptying, such as hand grip, which increases afterload, or that increase LV volume, such as squatting, which increases preload, will cause the mitral valve to prolapse into the LA later, pushing the click from mid to late systole and shortening the duration of the late systolic murmur. Let's take a listen at the murmur of mitral prolapse. Now let's take a listen to a murmur of mitral prolapse with only a mid-systolic click. Now let's touch upon the mitral valve anatomy, which is also fundamental to understand. The mitral annulus is a fibromuscular ring in a 2D shape of a D letter and a 3D shape of an elliptical saddle. The anteromedial part of the mitral annulus shares the same wall as the aortic annulus and is more rigid than a posterior annulus, so dilation of the mitral annulus usually happens posteriorly. The posterior leaflet has 3 scallops from lateral to medial. The anterolateral scallop, so you can see P1 over here, the anterolateral scallop, or P1 over here in this diagram, P2, which is the middle scallop, and P3, which is the posterior medial scallop. P2 is the largest scallop of the three. The anterior leaflet has three segments, from lateral to medial, the anterior segment, the middle segment, A2, and the posterior segment, A3. The anterior leaflet does not actually have true scallops, but is arbitrarily divided into three segments, A1, A2, and A3, for practical purposes to match the scallops P1, P2, P3, which are, again, the anterolateral scallop, the middle scallop, and the posterior medial scallop. Remember that the aortic valve is anterior to the mitral valve, and they are joined by the aortomitral curtain. The coronary sinus runs along the posterior aspect of the mitral valve. Over here, you can see in purple, and it goes from P3 to P2 to P1. Mitral regurgitation is classified by whether it is primary or secondary. Primary meaning abnormal leaflet or cord, secondary meaning normal leaflet and cord. On the other axis, mitral regurgitation is also classified by whether it is Carpentier type 1, which is normal leaflet motion, Carpentier type 2, which is excess leaflet motion, or type 3, which is restrictive leaflet motion. It is also classified into acute MR and chronic MR. Let's go through each of these systematically. In type 1 MR, the leaflets have normal mobility but poor coaptation due to annular dilation or perforation or cleft or indentations of a leaflet. Leaflet perforation or leaflet cleft, which are considered primary MR, can result from endocarditis, congenital malformation, or iatrogenic trauma. Atrial and annular dilation, which are considered secondary MR, are associated with chronic atrial fibrillation or HFpEF, both resulting in progressive remodeling of the LA. Increases in LA pressures result in annular dilation and flattening. Notably, in type 1 MR, there will be normal LV dimensions, papillary muscles, chordae, and leaflets. In type 2 MR, there will be excessive motion of the margin of a leaflet segment above the annular plane. There is leaflet redundancy. This is considered primary MR. The two classic examples of type 2 MR are mitral valve prolapse and leaflet fail with ruptured chordae. This can both happen in myxomatous mitral disease or fibroelastic deficiency, which are both instances of degenerative disease. Barlow disease involves excessive myxomatous tissue due to accumulation of mucopolysaccharides in leaflets and chordae. The leaflets thicken, become bulky, lead to redundant valvular tissue with redundant billowing leaflets. The chordae elongate or rupture. This is usually diagnosed in young adults who present with bileaflet and multisegmental prolapse, sometimes with flail scallops. They are followed with serial echo over decades until indications for surgery are met in their fifth decade of life. In contrast, patients with mitral regurgitation from fibroelastic deficiency are usually in their 60s and present with a short history of localized or unisegmental mitral valve prolapse or flail. Only one segment should prolapse or flail, although multiple chordae can be affected. Fibroelastic deficiency is the most common organic mitral regurgitation for which mitral valve repair surgery is needed. Now, in type 3 MR, there is restriction in leaflet mobility, resulting in coaptation of leaflets while they are at the ventricular level. Type 3A MR is restriction in leaflet opening, so the restricted leaflet motion occurs in both systole and diastole and is considered a primary MR. It can result from rheumatic heart disease, carcinoid disease, radiation, or mitral annular calcification. The aforementioned entities all have thickening, retraction, and rigidity of leaflets and attached chordae, thus restricting both systolic and diastolic leaflet motion. Type 3B MR is restriction in leaflet closure, so the restricted leaflet motion occurs in systole only and is considered a secondary MR. It results from conditions which lead to displacement of the papillary muscles away from the mitral annulus and systolic tethering of the mitral leaflets transferred through through tense chordae tendineae, which can be seen in ischemic cardiomyopathy or dilated cardiomyopathy. Note that type 3B MR has intact leaflets, just like type 1 MR, except in the cases of leaflet perforation and cleft. Now that you have a good understanding of the classification of the types of MR, you also need to understand the classification of the severity of MR. Quantifying the severity of mitral regurgitation depends on a range of echocardiographic parameters. I will go over the 3 quantitative parameters since they are the most testable on the exam: EROA, regurgitant volume, and regurgitant fraction. Let's review how to calculate EROA and regurgitant volume by the PISA method. Proximal to the plane of the valve, acceleration of flow occurs in a series of isovelocity surfaces converging in the high-velocity jet at the regurgitant orifice. The same volume of fluid that occupies the first or outermost hemisphere has to make it through the second hemisphere, third hemisphere, etc., until it reaches a narrow regurgitant orifice. Thus, it is forced to accelerate. For each concentric proximal isovelocity area, or PISA, the radius r is used to calculate the PISA. The surface area of a sphere is 4 pi r squared, so the surface area of a hemisphere is just 2 pi r squared. Flow at the vena contracta is the effective regurgitant orifice area, EROA, in centimeters squared multiplied by the MR peak velocity in centimeters per second. Flow at the PISA shell is the surface area in centimeters squared calculated by 2 pi r squared multiplied by the aliasing velocity in centimeters per second. These two flows have to be equal to each other. Rearranging, we can get EROA on the left equals surface area PISA times aliasing velocity divided by MR velocity. Let's walk through an example with specific numbers so you can understand how to do this. In this patient with mitral regurgitation, the PISA radius is 1.1 centimeters and the aliasing velocity is 35.9 centimeters per second. You can see that over here, it's circled 35.9 centimeters per second aliasing velocity, and here's the PISA radius of 1.1. Since regurgitant flow Q equals 2 pi r squared times the velocity of the aliasing, the regurgitant flow is 2 pi times 1.1 centimeters squared times 35.9 centimeters per second. That gives you 272.9 centimeters cubed per second, or 273 milliliters per second. That is your regurgitant flow. Then, by the illustrated equation above, this one over here, EROA equals the regurgitant flow that was already calculated by the MR V max, velocity max. So that's 273 centimeters cubed per second divided by 640 centimeters per second. That gives you 0.427 centimeters square, which can be rounded up to 0.43 centimeters square. That is your effective regurgitant orifice area. Since this ERO area is more than 0.40 centimeters square, it suggests severe mitral regurgitation. We can take that further to get the regurgitant volume. The regurgitant volume, R-vol, equals the EROA times the VTI of the regurgitant jet. So that's 0.427 centimeters squared times 213 centimeters. That gives you 91 centimeters cubed. Since 91 milliliters is more than 60 milliliters inclusive, it suggests severe mitral regurgitation. Note that 91 milliliters, the regurgitant volume, is how much gets pushed back across the mitral valve per cardiac cycle, whereas the 273 over here, the regurgitant flow, is how much volume gets pushed back across the mitral valve per second. Finally, beware that if the surface is not planar, as you can see here in this top right illustration, meaning if the PISA shell is not a complete hemisphere because the jet is eccentric, Then you have to apply an angle correction factor alpha to your EROA. Although PISA is great, PISA is not accurate if the jet is eccentric, or if there are multiple jets, or if the isovelocity surface area is not a hemisphere. An alternative method is to determine the regurgitant volume by the concept of volume displacement. Regurgitant volume backward across the mitral valve, R valve, is just the LV stroke volume that makes it forward across the mitral valve minus the stroke volume that makes it forward through the LV's outflow tract, SVLVOT. Each of these stroke volumes can be obtained by multiplying the cross-sectional area by the velocity time integral, CSA times VTI, for both the LV outflow tract stroke volume and the mitral valve stroke volume. The regurgitant fraction will then be the regurgitant volume out of the total stroke volume. And how do we obtain the cross-sectional area of the LVOT and MV? This can be easily done by drawing a line across these tracks to measure their diameter in 2D echo. The formula for the area of a circle, A equals pi r squared, can be easily applied, except the diameter must be halved to become a radius. Let's walk through an example with specific numbers. The top left panel shows LVOT cross-sectional area being obtained by drawing a line to measure the diameter of the LVOT, which is 2.5 centimeters. This double-headed white arrow over here that I have boxed in this red box. Cross-sectional area of the LVOT is pi times the square of the width of the LV outflow tract divided by 2. So that's 2.5 centimeters divided by 2 squared times pi. That gives you 4.91 centimeters square as your cross-sectional area of the LV outflow tract. In the top right panel, the LVOT VTI is 13.6. So the stroke volume of the LVOT is the cross-sectional area times the VTI. So that's 4.91 centimeters squared times 13.6 centimeters. It gives you 66.7 centimeters cubed, or milliliters. In the bottom left panel, the diameter of the mitral valve annulus is 4.5 centimeters, as indicated by the double head white arrow that I have boxed in red. So the cross-sectional area at the mitral valve is pi times the square of 4.5 centimeters divided by 2. That gives you 15.90 centimeters square. In the bottom right panel, the mitral valve VTI is 11.7 centimeters. So stroke volume in the mitral valve equals CSA mitral valve times VTI mitral valve, which is 15.9 centimeters squared times 11.7 centimeters. That gives you 186 centimeters cubed, or milliliters. Now that we know that the stroke volume at the LV outflow tract is 67 milliliters and the stroke volume of the mitral valve is 186 milliliters, we can easily subtract to find a regurgitant volume. Regurgitant volume is 186 minus 67, which is 119. 119 divided by 186 milliliters is 64%, so the regurgitant fraction is 64%. Since this is more than 50% inclusive, it suggests severe mitral regurgitation. Apart from the quantitative criteria, there are numerous qualitative criteria to assess MR severity, such as the flow convergence, the color flow jet area, the mitral valve morphology, and the nature of the continuous wave Doppler jet, whether it is holosystolic, dense, and triangular. I will not dwell on these due to limited time. Now that we know how to quantify mitral regurgitation severity, what do we do about it? Any severe primary mitral regurgitation that is symptomatic automatically gets intervention by replacement, with repair if possible, class 1, else replacement. Mitral valve repair is strongly favored over replacement in isolated severe primary MR limited to half the posterior leaflet, such that annuloplasty and posterior leaflet repair are sufficient. Mitral valve replacement is inappropriate unless mitral valve repair has been attempted and was unsuccessful. Mitral valve repair is greatly preferred over mitral valve replacement because of preserved LV function, lower operative mortality rate, and lower rate of complications associated with prosthetic valves in the long term. For symptomatic, it is straightforward. It is the asymptomatic patients in whom you need to pay attention to LVEF and LV end systolic diameter. If the severe primary MR patient is asymptomatic, you can still get replacements if the EF is 60% or less. That's a class 1 indication. Why? The goal of the MR intervention is to correct it before LV systolic function takes hold. Because if moderate LV dysfunction develops, prognosis will be worse even after mitral valve surgery. The ideal time for mitral valve surgery is when the LV is just approaching systolic dysfunction at an EF of 60%. Why is the EF cutoff 60% in MR, you might ask, instead of the 50% used in AR? Because the loading conditions in MR allow for continued late ejection into a lower impedance LA. So the EF is artificially elevated in severe MR, and a higher cutoff for normal EF is used, 60% instead of 50%. You can also get replacement in asymptomatic severe primary MR if you have an LV end systolic diameter of 40 millimeters or more, class 1. Why do we care about LV end systolic volume and diameter, LVESD? Well, MR causes LV dilation, stressing the mitral apparatus, worsening regurgitant volumes, perpetually increasing LVESD. Chronic volume overload leads to irreversible LV dysfunction and poorer prognosis. Remember that normal LV end systolic diameter is 40 millimeters or less in men and 35 millimeters or less in women. Recall that the LVES diameter that prompts referral for AV replacement in aortic regurgitation in the last session is more than 50 millimeters, whereas the LVESD that prompts mitral valve surgery in MR is LVESD of 40 millimeters or more. Now, what if you are asymptomatic and you have a preserved LVEF and a normal LVESD? You can still get mitral valve replacement if there is atrial fibrillation due to mitral regurgitation, or if there's pulmonary hypertension with a PA systolic pressure of more than 50 millimeters of mercury. That is a class 2A indication. Or if there is left atrial dilation, which is defined as over 60 milliliters per meter square of LA volume index. They also mentioned that mitral tear, such as MitraClip or Pascal, can be considered in symptomatic severe primary MR patients who are inoperable or at high surgical risk. Class 2B recommendation. Now that we have understood all of that, we can walk through the flow chart in the guidelines. Management of patients with severe chronic primary mitral regurgitation. First question, as always, is are there symptoms? If severe and symptomatic, the answer is obvious. You send the patient to a heart team discussion. If there's a high risk of futility, then it is conservative management. If the patient's inoperable or high surgical risk, then you can consider TEER if anatomical suitable. TEER meaning MitraClip or Pascal. If they are not at high surgical risk and they're operable, then you want to do surgery, and repair is preferred over replacement when you do surgery. Now, what about the left side of this flowchart? What if the patient has no symptoms, but they have severe chronic primary MR? Then you look at the LV end systolic diameter and the LV ejection fraction. Remember, unlike in AR and where you look at EF of 50% and LVESD of 50, here we are looking at LV ejection fraction less than 60% and LV end systolic diameter of more than 40 millimeters. So if you have either of those things, then yes, you can go to surgery and again, repair whenever possible. If you don't have those things, it's still possible for you to send a patient to surgery if they have new onset AFib that is thought to be related to the mitral regurgitation, or if the PA systolic pressure exceeds 50 millimeters of mercury. Unfortunately, there is limited evidence that mitral valve surgery improves survival in secondary MR, even symptomatic secondary MR. So the guidelines are worded much more restrictively when it comes to secondary MR. In secondary MR, regurgitation is caused by annular dilation as well as by apical and lateral displacement of the papillary muscles. Thus, durability of the repair is dependent primarily on regression or progression of ventricular dilation. We only reluctantly pursue mitral valve surgery if GDMT doesn't work. Mitral valve surgery does improve symptoms and quality of life in patients with severe secondary MR who have symptoms despite GDMT. Mitral valve surgery reduces chamber size and improves peak oxygen consumption. So you can give mitral valve surgery in severe secondary MR if you have done full GDMT and or CRT, and that's a class 1 indication. Severe secondary MR is only given mitral surgery if they are symptomatic. There's no indication for mitral valve surgery for asymptomatic severe secondary MR. Of course, if they're undergoing CABG or other cardiac surgery, then it is a class 1 indication to get the mitral valve surgery done for severe secondary MR. As for repair versus replacement, in a randomized trial of mitral valve repair versus replacement in severe secondary MR, ischemic MR, there was no difference in survival or LV remodeling at 2 years, but there was higher recurrence of moderate to severe MR in the MV repair arm than the MV replacement arm, leading to higher heart failure incidence and a repeat hospitalization. Whereas in primary MR, mitral valve repair is favored over mitral valve replacement wherever possible. In secondary MR, mitral valve repair is less durable, so there's no strong preference of mitral valve repair over replacement. Now, as for this part about TEER, who should get mitral TEER, meaning mitral clip or Pascal? And I only mentioned those two because those are the two the biggest ones on the market, but there are many others, and I'm not trying to favor any one particular brand or company. Okay, I'm just talking about transcatheter edge-to-edge repair in general. Because the guidelines are 4 years old now and this area has evolved, I want to show you the most current framework for thinking about mitral TEER. You have 3 huge trials in this area. The COAP trial showed improved survival, heart failure hospitalization, symptoms, and quality of life from TEER versus GDMT for secondary MR. The MITRA FR trial, which showed no benefit in survival, heart failure hospitalization, or symptoms from TEER versus GDMT for secondary MR. And the ReShape Heart Failure 2 trial, which showed improved heart failure hospitalization and symptoms from TEER versus GDMT, again for secondary MR, although there was no difference in mortality. The discrepancy results of these 3 trials can be reconciled by the LV volume framework. The ability to modify outcomes is tied to how much the MR is driving heart failure versus how advanced the underlying LV disease is. Smaller LV volumes, such as in COAT, where the mean LV end diastolic volume is 192 milliliters, suggest MR as a major driver of heart failure and thus responds well to MTEER. Larger LV volumes, such as in MITRA FR, where the mean LV end diastolic volume was 252 milliliters, suggest advanced remodeling, where MTEER is less effective. Putting everything together, let's zoom in on the top half of the final flowchart. Management of patients with chronic severe secondary MR, if they have symptoms despite GDMT. So you talk to the heart team, GDMT optimization, CRT if needed. If they have severe comorbidities or their life expectancy is less than 1 year, consider conservative management or referral to palliative care. If not, see if they have coronary artery disease requiring treatments or other cardiac disease and try to address those as well. If they don't, and they have persisting severe secondary mitral regurgitation and symptoms, then you can go to this bottom half of the flowchart. If they're appropriate for valve surgery, you can go ahead for mitral valve surgery down here. If they're not, then you look at whether they have fulfilled criteria suggesting an increased chance of responding to TEER. If they do, you can give them this transcatheter option of TEER. If they don't, then it's going to be more complicated, and the decision about TEER should be made in the context of any available trials, as well as a careful evaluation for heart transplant or LVAD. If they have end-stage LV or RV failure and they're not appropriate for valve surgery, then another option is to consider heart failure, heart transplant or LVAD. In the remaining time, we'll move on from mitral regurgitation to mitral stenosis. These are the ESC knowledge competencies for managing a patient with mitral stenosis. Again, back to fundamentals. What does the murmur of mitral stenosis sound like? The timing is diastolic. You can palpate carotid arteries or correlate with telemetry to determine diastole, of course. The character is an opening snap with a low-pitched diastolic rumble located at apex. You will want to use the bell of the stethoscope and position the patient in a left lateral position. How this happens is that the stiff mitral leaflets rapidly open during diastole but abruptly halt midway, causing an opening snap, followed by a diastolic murmur as the high-pressure LA tries to force flow into the LV through the restricted orifice. The intensity is proportional to the mitral stenosis gradient. And in terms of maneuvers, mitral stenosis murmur is increased with anything that increases heart rate or cardiac output, such as exercise. Let's take a listen. Okay. In terms of etiology, 60% of mitral stenosis is from rheumatic heart disease, and 20% of mitral stenosis is calcific degenerative mitral stenosis, previously known as senile calcific mitral stenosis. And needless to say, that these percents vary widely depending on the part of the world that you are practicing in. So I think it's important to be able to recognize rheumatic mitral deformity on echo. In parasternal short axis, you will see a classic fish mouth appearance due to fusion of the medial and lateral commissures of the mitral valve, which you can see as the green arrow and arrowhead in the figure, reducing the mitral valve area. There will be restricted mitral leaflet motion. In off-axis parasternal long axis view, you can see the chordae tendonae shorten, thicken, which is the yellow arrow in the figure here, and become fused altogether. Chordal abnormalities begin at the points of the leaflet attachment and progressively extend towards the papillary muscles. In parasternal long axis, you will see distinctive diastolic doming, known as the hockey stick appearance, also referred to as dogleg deformity, of the anterior mitral leaflet caused by commissural fusion, that's the yellow arrow in this figure. It is also possible for the posterior mitral leaflet to dome, but it is more often immobile. The pathology usually seen in a posterior mitral leaflet is restricted motion. In the bottom half, you can see the restricted motion of the posterior mitral valve leaflet in systole, that's in panel A, and diastole in panel V. There's barely any change in the position of the posterior mitral valve leaflet. Meanwhile, the hockey stick deformity of the anterior mitral valve leaflet is seen in diastole in panel B. The restricted posterior leaflet can give rise to significant mitral regurgitation, which you can see on the color Doppler in panel C. How do you assess mitral valve stenosis severity? There are only two parameters that are commonly used, unlike in AR, AS, and MR. In mitral stenosis, you only talk about the area and the gradient. What is the pressure half time? The pressure half time is the time interval between the maximum mitral gradient in early diastole and the point where the gradient is half of the maximum value measured in milliseconds. The smaller the mitral stenosis orifice, the longer it takes for the pressure to decline. The top plot shows the pressure of the left ventricle and the pressure of the left atrium in two red lines, the difference between the lines being the pressure gradient across the mitral valve. Over this time, the velocity across the valve decreases from Vmax to Vmax over square root of 2. Since 1 over the square root of 2 is 0.7071. We estimate the latter as 0.7 Vmax. So another way to think about pressure half time is that it is the time it takes for the peak mitral inflow velocity to decrease by 30%. Some people have asked me, okay, but why is it 1 over square root 2? So I have derived the math for you here for anyone who is interested. Mitral valve stenosis area can also be measured by planimetry tracing, ideally on 3D echo, if not by 2D echo, or calculated by pressure half time on 2D echo. If you're unable to directly trace the area of the mitral valve on echo, you can calculate the mitral valve using pressure half time and deceleration time. You need to know, if you are given deceleration time, how do you get pressure half time from that? That's a very testable question. Just multiply by 0.29. Pressure half time is 0.29 by deceleration time. Why does this work? Notice that deceleration time, you can see over here, this green one, dt, and pressure half time, pht, in red over here, both make up the base of proportional right angle triangles. And 1 over square root of 2 is 0.7071. So the complement of that is 1 minus 0.707 equals 0.293. That's where this rounded up 0.3 comes from. Since the height of the orange triangle is 0.707, the height of the overall triangle, the height of the small triangle is 0.292, the height of the overall triangle, and the bases are similarly proportional. So the pressure half time is just 0.293 of the base of the overall triangle. That's how you get pressure half time equals 0.29 times deceleration time. In terms of the area itself, in the past, mild would be more than 1.5, moderate 1.0 to 1.5, and severe less than 1.0, but that classification system is no longer used. The current guidelines only make a distinction between 1.5 centimeters square for severe and non-severe. So a mitral valve area of less than 1 centimeter square would be very severe mitral stenosis. Less than 1.5 is severe, and more than 1.5 is not severe. In this example here of a single patient with mitral stenosis, panel A shows the mean gradient is 11 millimeters of mercury at a heart rate of 70 beats per minute, which is a significant gradient because it's more than 5 and also more than 10. Panel B shows that the pressure half time, indicated by the time it takes to go from a Vmax of 2.1 meters per second to a Vmax over square root 2 of 1.5 meters per second, is 235 milliseconds. And 200 divided by 235 gives a mitral valve area of 0.94 centimeters per second. Sorry, 0.94 centimeters square. That is less than an area of 1.5. So that's also severe. Panel C shows that the deceleration time is 802 milliseconds. Since pressure half time is 0.29 times deceleration time, 802 times 0.29 equals 0.94 centimeters square, or 0.95 centimeters square, depending on your significant digits. So all of this is consistent with a severe mitral stenosis. The guidelines for management of mitral stenosis are quite straightforward. Percutaneous balloon mitral commissurotomy is recommended for patients with favorable characteristics, class 1, or who cannot get surgery, class 1. Otherwise, they get sent for surgery, class 1. So what are the favorable characteristics and what are the contraindications? The 4 components of the Wilkins score for percutaneous mitral balloon commissurotomy are the mitral valve leaflet mobility, thickness, calcification, and subvalvular thickening. Each of these parameters is graded from 1 to 4. You add up the points for a total score of 4 to 16. Scores up to 8 predict good results in terms of reduction of the transvalvular gradients via balloon valvuloplasty, whereas more than 8 suggests that they are not suitable to do a PMBC. The score needs to be 8 or less out of 16 to do the balloon. What about contraindications to PBMC? Presence of significant mitral regurgitation at baseline is a contraindication to balloon valvuloplasty. Why? Because MR tends to increase following balloon valvuloplasty for MS. So patients with moderate or greater MR should not undergo PBMC. If moderate or severe MR is present, you have to treat the MS with surgical MV replacements. Other contraindications to PBMC for MS are persistent LA thrombus, severe or bicommissural calcification, because the mechanism of successful mitral valvuloplasty is commissural separation. The presence of heavy calcification is an impediment and will lead to lower procedural success and higher incidence of significant mitral regurgitation, and concomitant valve or coronary artery disease requiring surgery. What about for asymptomatic patients? PBMC can be given to asymptomatic patients if they have significant pulmonary hypertension, a need for major non-cardiac surgery, a desire for pregnancy, or high thromboembolic risk, such as a history of PE or paroxysmal AFib. This can be done as long as they do not have unfavorable characteristics for PMC, defined down here. So with that, we can understand the flowchart for management of rheumatic mitral stenosis in the guidelines. First, you ask, do they have symptoms? If yes, see if they have any contraindications to percutaneous balloon mitral valvuloplasty. If they do, yes, then you go down to surgery. If they don't, then see if they have any contraindication or if they are high risk for surgery, and if they have favorable anatomic and clinical characteristics. If the answer is yes, then you can do the balloon PBMC. If the answer is no, then you send them to surgery. On the other hand, if they have no symptoms, you can still send them for intervention if they have a high risk of embolism or hemodynamic decompensation, or if they have symptoms on exercise stress testing, assuming that they do not have any contraindications or unfavorable characteristics for PBMC. That is everything that I wanted to go over for you in this rapid review of mitral regurgitation and stenosis and the ESC guidelines. Thank you very much for having me here.